My name is Mark Socinski. I'm the Executive Medical Director of the Advent Health Cancer Institute in Orlando, Florida. I am a thoracic medical oncologist, and I'm a member of the Institute's thoracic oncology program, actively seeing a large volume of lung cancer patients, as well as continuing many clinical investigations in the thoracic malignancy space. In patients with extensive stage small cell lung cancer who do not have brain metastases at the time of diagnosis, how often should the brain be surveyed for the development of brain metastases? It's important that in extensive stage disease, you realize that at least 10% of patients have brain mets at the time of diagnosis. And so CNS staging, optimally with brain MRI, is done routinely in this population. Again, 10% or so of patients will already have brain metastases, but the majority won't. And then the question comes up, how often should you repeat CNS imaging? And to me, that kind of depends on how the extensive stage disease reacts to treatment. If you have a patient who has a very deep response to a systemic therapy, and again, the standard of care in this setting is platinum etoposide with either atezolizumab or durvalumab with continued maintenance of immunotherapy after 4 cycles of treatment, at least in my practice. Some might give 6, but I give 4, and then go to maintenance therapy. If they have a deep response, and it looks like, certainly with immunotherapy, we can be optimistic that perhaps that response will be durable. Although we know that both chemo and immunotherapy are active in the brain, we also know, I think, or at least the general feeling is that early detection of brain metastases may allow prevention of symptoms and early palliation in this particular setting. So in those patients that have those great responses out of the gate, then probably I would repeat a CNS imaging, assuming there are no symptoms of CNS concern. Then I would repeat the brain MRI perhaps every 6 months or so. I have a very low threshold for repeating brain imaging if there's anything that sounds like it might be a CNS symptom, because you want to detect it early. On the other end of the spectrum, you have patients who don't respond well, who basically at best have stable disease. Those patients are probably not going to be the good actors, so to speak. I would be a little bit looser in terms of how often I might image that, because I think the issue there, although I don't want to discount CNS progression, I think the main issue there is systemic progression in that population. And certainly I'm less aggressive about CNS imaging in that setting. In fact, I may only do it in those cases on an as needed basis in that setting, mostly symptom driven. And then of course you have all those people in the middle that might have a bit of a response, and you have to make a judgment call in that setting. But that's kind of how I look at those patients who do not have CNS involvement at the time of diagnosis.